So good morning, everyone. The task for today for myself is KRAS in non-small cell lung cancer. This is the list of my disclosures. Part of the question that Giorgio just asked, why different tumors respond to different strategies in a different way, is related to differences in the spectra of mutations in these tumors. Here you can see the list of different tumors according to the percentage of RAS mutations, including KRAS, but also HRAS and NRAS, giving you examples of pancreas, colorectal, and biliary tract carcinomas harboring commonly these mutations. Lung falls in between with about 20% RAS mutation rate, predominantly KRAS, and also KRAS and other RAS mutations are common in many other malignancies as listed here and also of this list. You can see also on the bottom of the slide that the spectra of KRAS mutations in terms of position 12 and 13, the most common KRAS mutations, are markedly different among these tumors. And what's the biological significance of different types of mutations, transversions versus transitions, for example, is not well understood. In non-small cell lung cancers, typically in smoking patients with adenocarcinomas, the rate of KRAS mutations, KRAS are most common in non-small cell lung cancer, is between 20 and 30%, but also you can observe a low percentage of KRAS mutations in adenocarcinoma patients who never smoked. This is in the range of 2 to 6%. Finally, squamous cell carcinomas harbored about 5 to 10% KRAS mutations in about 5 to 10%. Transversions are typical for smokers versus transitions, which are typical for never smokers. And here I would like to mention about one interesting entity that I have seen in the clinic several times, which is Mucinous adenocarcinoma with bronchioalveolar features. You may remember that according to WHO classification, we have 5 subtypes of lung adenocarcinomas, of which lipidic adenocarcinoma is one. And lipidic adenocarcinoma can be divided into non-mucinous type, in which EGFR mutations are quite common, versus mucinous type, in which, according to this publication, but also many others, KRAS mutations are quite common. These patients often present with kind of pneumonia picture on the initial chest X-ray that can be treated with antibiotics for months even, and then are found to have lung adenocarcinoma lipidic growth, typically when mucinous with KRAS mutations, often never smokers. Now this slide gives you an overview of types of KRAS mutations in non-small cell lung cancer in codons 12 and 13, in exon 2. The other KRAS mutations in codon 61 are far less common, less than 5%. Codon 12 mutations are most common, of which G12C, G12D, and G12V are most prevalent. Again, the slide gives you an overview of RAS signaling pathway. In RAS mutant non-small cell lung cancer, RAS is in the active state, bound to GTP, with downstream signaling pathways such as RAS, RAF, MEK, ERK, and cyclin D1 pathway, but also activation of PI3K, ACT, and mTOR pathway, and other pathways as well, as for example the RAL pathway. Something that we quite poorly understand is how different types of KRAS mutations contribute to different downstream signaling pathways, and probably this analysis will give us more biological insight why different KRAS mutations behave in a different manner in terms of predictive role and first of all biology. Few slides on KRAS mutations and prognosis. This is an overview of several studies that were published on the subject of KRAS as poor prognostic factor in some of these studies. In the bottom of this list, you can see the meta-analysis from Céline Mascot, published over 10 years ago, which gives us hazard ratio of 1.35, mainly surgical series. And you can see here on the list that more Far East studies are related with KRAS reported as poor prognosis, whereas Western studies do not typically find this association. This is mainly due to the fact that KRAS mutants are mutually exclusive with EGFR mutations, and the EGFR mutation proportion is higher in the Far East. So if you compare patients with KRAS mutants to the KRAS wild type, the proportion of EGFR mutants will be higher in the Far East, and these patients do better. So a very good study on KRAS mutations and prognosis can be found in the March issue of Journal of Thoracic Oncology, in which colleagues from NCIC of Canada analyzed several placebo-controlled trials with EGFR inhibitors, and in the placebo groups of these trials, KRAS mutations were not prognostic at all. So these studies are mostly Western studies telling you that KRAS mutations are not truly prognostic in our populations. This is a summary slide on prognostic significance of KRAS. Maybe there is a weak association with worse prognosis, but this is not due to biological significance of KRAS probably, and the Western population data do not support the above. And again, this association has limited clinical utility. Now, if we talk about KRAS mutations and prediction of benefit from chemotherapy, there is again a large body of literature on that, of which, to cut to the chase, two studies are of importance to remember. One is the adjuvant study published by NCIC group, the BR10 study, in which adjuvant cisplatin vinorelbine was associated with clinical benefit in adjuvant setting in patients with stage 2 and 3 non-small cell lung cancer in post-surgical setting. Interestingly, in this study, patients were stratified by KRAS mutation status, and those without KRAS mutations had a benefit in terms of hazard ratio of roughly 0.7, whereas this benefit was not observed in patients with KRAS mutations, with hazard ratio of 0.95. However, interaction test comparing hazard ratios was not significant, so we cannot truly say that KRAS mutations are predictive for the lack of benefit from chemotherapy. Another important study that was shown in ASCO 2012 and published later was a meta-analysis of adjuvant studies with KRAS mutation analysis. In this study, non-significant trend for benefit from adjuvant treatment was observed in wild type, but not in patients with codon 12 KRAS mutations. Interestingly, in patients with codon 13 mutations, again, small number of patients, chemotherapy was deleterious, although this observation is hampered by small number of patients. So in conclusion, KRAS mutations cannot be used to predict who will benefit from chemotherapy in adjuvant setting and also in advanced setting as of today. KRAS mutation and prediction of benefit from EGFR TKIs is quite an obsolete question because we now select patients based on EGFR mutation status. However, if we treat patients in the second or third line with EGFR wild type status, and those patients harbor KRAS mutations, we can expect response rate rather in the proportion of close to 0, and median progression-free survival is really low in this patient category. Again, quoted study from JTO this March analyzed placebo-controlled trials, patients treated with EGFR inhibitors, and in patients with wild-type EGFR status, KRAS mutation status did not have any association with overall survival of these patients. However, the authors also noted that some KRAS mutant patients, some types of KRAS mutations were associated with a worse outcome than the other patients. In summary, KRAS mutations are mutually exclusive with EGFR mutations, or almost mutually exclusive, as there were cases occasionally with both mutation types. The latter are commonly used to select patients to EGFR TKIs, and the significance of KRAS mutations as negative predictors to EGFR TKIs in patients with wild-type EGFR is these days of less clinical interest. However, patients who harbor KRAS mutations are really unlikely to respond to EGFR TKIs. That's something that I should stress. It was already mentioned that KRAS mutations are used as negative predictors for benefit from anti-EGFR monoclonal antibodies in colorectal cancer, cetuximab and panitumumab. The body of evidence to use KRAS mutations for the same strategy in non-small cell lung cancer is now established, with 2 studies exploring the addition of cetuximab to carbopaclitaxel or cisphenoyrelbine, showing that in terms of progression-free survival or overall survival, hazard ratios are pretty similar, and then there is no advantage of taking into consideration KRAS mutations. These are not predictive for the small benefit of EGFR monoclonal antibodies when added to chemotherapy, strategy that is not used in the clinic today. So unlike in colorectal cancer, KRAS mutation status in non-small cell lung cancer does not predict for the benefit from cetuximab. Now, couple of slides on KRAS as therapeutic target. This has basically been the holy grail of cancer therapy. KRAS mutations were first described in 1983, so over 30 years ago, and since that time, we still have limited clinical utility in targeting KRAS mutations in such a common malignancy as lung cancer. The first setting of different molecules that were developed against RAS protein was associated with our knowledge on how RAS is processed in the cell. You can see here a nice review picture showing you different steps of RAS processing in the cell, starting from farnesylation of the protein, and then different RAS proteins, KRAS, HRAS, or NRAS, are processed in the endoplasmic reticulum, Golgi apparatus, and then docked to the plasma membrane when a RAS protein can be active. Of interest, the early clinical trials with farnesyltransferase inhibitors, either lonafarnib or tipifarnib, have been unfortunately unsuccessful in KRAS mutant pancreatic cancer, but also non-small cell lung cancer. This is partially due that the process of farnesylation can be done in 2 different ways, and the early farnesyltransferase inhibitors were only inhibiting one of them. Some new data on another agent, which is called salirasib, which is a novel farnesyltransferase inhibitor that's competent for the docking site of the KRAS in the plasma membrane, so the last step of the processing. Again, this drug has not fulfilled its promise and was not associated with objective responses in recently published phase 2 non-small cell lung cancer clinical trial. However, I should mention that the other strategies related to processing of the RAS protein in the cell are currently being developed. Now, RAS itself is a very difficult target to directly target, so the strategies of targeting directly KRAS protein are still in preclinical development. There are many studies, however, that take into consideration the KRAS downstream target proteins. The problem here is that we have a couple of pathways downstream of RAS, not only RAF, MEK, and ERK pathway, but also PI3K, AKT, and mTOR pathway, and also RAL pathway that was mentioned already, and also quite some others. So in order to be effective, you probably have to target at least two of these pathways. And early clinical trials, for example, with MEK inhibitors, including selumetinib, have shown that it is insufficient to target only one downstream protein of RAS. So combination strategies are being pursued in phase 1, phase 2 clinical trials, and also combination trials with chemotherapy. Some trials that need to be mentioned include sorafenib, which has been tested in a phase 2 setting. This is mainly RAF and VEGFR inhibitor, as you know. Sorafenib is ineffective as given alone in patients with KRAS mutations. Another important phase 2 and soon phase 3 data are on combination of MEK inhibitor selumetinib and docetaxel, as shown and published by Paziane and colleagues. I will briefly touch base on that. But also other important strategies to be mentioned are combination against MEK and AKT pathway, which are parallel pathways downstream of RAS, but also HSP90 inhibitors, mTOR inhibitors, which are also important targets downstream of RAS, and finally also a trial of combination of MEK inhibitors and EGFR inhibitors, which, by the way, has proven to be ineffective. This is the most important, as of today, strategy in patients with KRAS mutation positive non-small cell lung cancer. The results of phase 2 study that were released in 2013 showing you that in this phase 2 study there was an advantage of combination of selumetinib MEK inhibitor with docetaxel in the second line treatment of patients with non-small cell lung cancer that were KRAS mutation positive versus docetaxel alone. There was also a trend towards overall survival advantage. These led to 2 subsequent phase 3 clinical trials, one specifically targeting patients in KRAS mutant non-small cell lung cancer, one in KRAS wild type non-small cell lung cancer, SELECT 1 and 2 studies. Both studies completed their accrual, and the results should be released quite soon. In vitro, there are also other possible co-targets of in cell lines with RAS mutations identified through synthetic lethality screens. Here you have a list of these targets. Interestingly, CDK4 and because cyclin kinase inhibitors are also downstream of RAS, CDK4 and 6 can be interesting and important target. BCL-XL anti-apoptotic factor is another good example, but also other proteins that are in preclinical development. So with that, I have still half a minute to wrap up the KRAS talk. KRAS mutant non-small cell lung cancer is the most frequent oncogene-addicted thoracic malignancy. In non-small cell lung cancer, it's roughly 20 to 30%. The spectrum of KRAS mutations matters. There is probably wide biological significance of different mutation types, with transversions being perhaps of different clinical meaningness as compared to other mutations. KRAS mutations are probably not associated with worse prognosis in our Western population of patients. KRAS mutations are not predictive for the benefit from chemotherapy. They are used for selection of patients rather to exclude other possible mutations and to show patients specifically with this biological entity. However, the clinical utility of KRAS to specifically include patients in KRAS-directed therapy is limited at the moment. However, several important trials, specifically combination with MEK inhibitors with chemotherapy, but also many others, are currently underway. So we should be ready perhaps soon to more actively use KRAS mutation status to select our patients to targeted therapies. And also, it should be noted that KRAS mutations are only part of the story, because other molecular events that are leading to activation of KRAS, as for example NF1 mutations, may also be of clinical significance because the signaling takes place through KRAS pathway. I'll stop here and thank you for your attention and take any questions you may have.